he is from Poland, and he will be talking on allergy in patients receiving anti-epileptic drugs.
Okay, so I was asked to give this presentation. As you probably suspect, I know absolutely nothing about dermatology. I'm a cardiologist, but you know, after all, the skin is a very important organ which covers heart among other organs. So anyway, my very dear friend, Dr. Błaszczyk, she is a neurologist. She specializes in the treatment of epilepsy. And some of the drugs which are used in the treatment of epilepsy, they do induce certain skin reactions. So she prepared this lecture. I was talking with her over the Skype for a few times. So there we go. So the title of the lecture is Allergy in Patient Receiving Anti-Epileptic Drugs. So Barbara Błaszczyk, she's a physician, she's a PhD. She is a faculty at the medical school in Poland. That was some misunderstanding to the translation, so my apologies. She doesn't have any disclosure to speak of. So the epilepsy, this is a chronic neurological disease. It actually affects quite a number of people in the world. It's about 50 million people globally being diagnosed with the epilepsy. So incidence is about 2 million patients on an annual basis. So the anti-epileptic drugs are first-line therapy to control seizures. Right now, there are advancements in the treatment of epilepsy. Perhaps most promising is a surgical approach, and also they use that cryoablation of the certain parts of the brain, which eases the seizures. Those treatments are reserved for the very severely affected patients. So about 60% of the patients which are diagnosed, which presented with epilepsy, actually very often are treated with the first medication. In about 40%, or 60 minus 100 minus 60, about 40% of patients, they do require polytherapy. In a significant number of those patients, apparently there are significant adverse effects. So at the beginning of last century, there were just a handful of anti-epilepsy drugs, and they were really debilitating. People were almost comatose. They really couldn't function properly. So since about 80s and 90s, that was advancement of number of medications which are available. So as you can see, it's just a pretty dramatic increase of medications, number of medications. So what are idiosyncratic adverse events? So those are which are unexpected or unpredictable, which are fundamentally different from the dose-related side effects. In other words, you don't have to be being on a number of grams of medication. Sometimes even a single exposure would lead to the idiosyncratic adverse events. The most common side effect of those adverse events is a skin rash, which we've seen in other medicines. So this is not something which is anti-epileptic specific. A variety of idiosyncratic reactions, they include aplastic anemia, acute liver failure, and of course, as I mentioned, cutaneous reactions. So how often do those adverse events occur? So they, about 8 to 10% of patients, they do experience some kind of adverse reaction. And it's about 2 or 3% is hospitalized patients. It means those people which are really severely presentation of the disease. So cutaneous adverse reaction, which are maculopapular or pruritic erythematous rash, may occur within 4 weeks, and that happens actually in a fair amount of patients, about 15% of those patients. The most common cutaneous adverse reaction include generalized morbilliform rashes, and where it depends what you read, what literature you would encounter between 50 to 90%, and urticaria about 2 to 20%. Fortunately, mortality due to severe adverse effect, it's very low. It happens rarely, but it happens. It's pretty heartbreaking experience, about 0.1 to 0.3%. So pathogenesis of cutaneous adverse events. So we have we have 4 types of those reactions. So the type 1 could be immunoglobulin independent. Another type, which is type 2, would be cytotoxic pathology. immune complex type 3, and cell-mediated would be type 4. There are also non-immunologic adverse reactions related probably to the dose, to the exposure, to delayed cumulative dose. So a number of issues should be considered. And idiosyncratic, which are possible of the immunologic background, they are severe in case of DRESS or TENS or SJS syndrome. So the risk factors for adverse effects, when you have a patient presented, one physician obviously thinks who could have those adverse reactions, and kind of highlighted the female more often are affected than males. People at the elderly age, especially of their 6 decades of life, they're probably more prone to the adverse reaction. Also, a number of anti-epileptic drugs are based on aromatic drink, and they actually also are prone to the causing a skin reaction or adverse reaction. Also, when you have a patients on a multiple drugs, those about 40% of the patients requiring polytherapy, they would more often have adverse reaction. Also, sometimes when you don't titrate, you start with a higher dose, so that might be a situation which is prone to triggering adverse reaction. Or if you fast titrate, so you have a severely present patient, and within 2-3 days you increase the dose again. So those cases may be prone to the adverse reaction. This slide is actually presented of adverse events, rashes or cutaneous manifestation, and it's just frequency of those. How often do you see those? So it is also interesting. There's a certain cross-reactivity when the patient, for example, is on a carbamazepine. So this patient may cross-react to another drugs, and they have maybe prone to the, for example, if they treated with phentoin, about 60% of those patients may have skin reaction and so on. And here you have a listed percentage of the possible interactions. So drug-induced rashes are the most common type of the idiosyncratic reaction associated with anti-epileptic drugs, which I mentioned already. It's early onset, usually that occurs within 4 weeks, and systemic symptoms are usually absent. Sometimes you would see the fever presented. Maculopapular or erythematous pruritic rash are most common in those patients, and rash usually disappears within days after withdrawing of the drug or switching to another drug. Rash could be severe. Actually, there's an abbreviation, as we always have in medicine, abbreviations, scars, severe cutaneous adverse reactions, such as erythema multiforme or Stevens-Johnson syndrome or toxic epidermal necrolysis, which is really a severe reaction, quite often fatal. If you're talking about AED or anti-epileptic drugs, hypersensitivity syndrome, abbreviated AHS, fortunately they are not common. Onset of this particular clinical presentation happens within 2 to 8 weeks after initiation of the therapy. They could be severe, they could be life-threatening, and they kind of highlight it's a triad of the symptoms, which is fever, rash, and also involvement of the internal organs. So here are listed the manifestation of clinical features. So it could be fever, as I mentioned, skins we spoke about, but also internal organs that would pertain to a liver. Also renal kidneys could be affected, pneumonitis, and so on and so forth. So as a matter of fact, it appears that folks of the Asian descent or ethnicity are more prone to this particular presentation, which could be severe, could be fatal at times, and actually it was the FDA alert issued in 2007 in this regard. So about 10 to 15% of population of Chinese, of from Thailand or Malaysia, could encounter this. It's fewer of those patients living in India of the Indian descent are affected, and some Japanese or Korean. So Stevens-Johnson syndrome, which is probably also very severe presentation. It's very rare, but it happens. It's very unpleasant and very serious presentation. It happens between 1.2 to 6 per million patient years, so it's rarely, but when it happens, it happens. And toxic epidermal necrolysis, it's even more rare, between 0.4 and 1.9 million per people year. About 80 to 95% are associated with drugs, and it usually happens early on, within 1 to 8 weeks after the initiation of the anti-epileptic therapy. May actually occur even within hours if you have certain hypersensitivity among those patients after exposure to drug. And you see at the bottom right or bottom left on your screen, patient affected with the severely affected lower limbs. So this is systemic disease, I mentioned. It could affect conjunctiva or eyes, trachea, bronchi, digestive system, renals. It also may lead to acute renal failure, and quite often those patients actually end up in a dialysis unit. About 25% of them, they would have a pulmonary dysfunction. They, if prolonged track of the disease, they actually may end up with a fibrosis of the lungs. Typical, it's anemia, leukopenia, hepatitis, severe abdominal discomfort connected or associated with diarrhea. And of course you would have encephalopathy as well as myocarditis. And I don't really know what's the reason for myocarditis, but myocarditis, as you know, it's a severely may actually lead to the heart failure if disease is not treated. So dysfunction of the left ventricle, pulmonary hypotension, so on and so forth. So it could be severe, especially in the younger patients. So what is prevention? You know, patient with this particular genetic predisposition, HLA positive, as I mentioned, those Asians, they actually are prone to this allergic reaction. So the prevention is, of course, you have to stop the drug, which is number one rule, and you would treat those patients as they severely burn. So burn unit management. Of course, that would encounter the systemic steroid. You would put IV drip, immunoglobulin G, cyclosporin, and so on and so forth. So drug reaction with eosinophilia and systemic symptoms, or DRESS abbreviated. So it quite often happens on the very first exposure to drug, and usually occurs within 1 to 6 weeks after first initiation of the therapy. And it happens about 1 to 3,000 patients, which, you know, is not that rare what happens. Someone who practiced medicine for a while actually would see that. So it's generalized edema, morbifibrium rash, tense bulba, lip erosions, and so on. So it will also include fever as a sign of the systemic involvement. Patient would be presented with a pharyngitis, cervical adenopathy, atypical lymphocytosis, eosinophilia. Also, they may have hepatitis, nephritis, pneumonitis, encephalitis, and so on and so forth. So those are the symptoms of the systemic involvement. So this is the study which actually was presented by a colleague of mine, Dr. Błaszczyk, about a year ago. It was published. It's a study which involved a single center experience. They had about 300 patients treated, and about 10% of them, they actually develop a severe allergic reaction to the treatment. So there was, as I mentioned, feminine gender is a risk factor. So obviously there are more women in this particular study. Age very broad, between 18 and 79, but look at the mean age, about 61. So it could happen early on, but it usually affects older patients. You have a etiology of the epilepsy here, and I'm not going to go to seizure types. Obviously, I have no idea what the seizure types are. I know what the seizure is, but that's about it. And the adverse event, anti-epilepsy drugs therapy, it's a monotherapy. It happened about 17 patients, and polytherapy about 13. So this is kind of half and half. actually more on a monotherapy than polytherapy, which I mentioned before, which was a bit surprising. So here on this slide you have a description of what kind of symptoms those patients had. They have a rash, urticaria, erythema nodosum, and Stevens-Johnson syndrome. Actually, that was in 6 patients, which was treated successfully in this case. So again, I'm not going to go through all the medicines who actually were patients taking. So I think this is the very important slide, because in conclusion, so what do you really do? What you have to be aware when you treat a patient with epilepsy? So skin rash actually appears about 3 to 10% of the patients, so could be treated in a symptomatic manner, but sometimes you just have to change the medication. But be aware, if someone developed the rash one drug, it has a higher chance of developing another adverse reaction when taking another, especially among the aromatic medicines. Risk of skin reaction is increased with a higher starting dose, so usually you probably want to titrate it and want to titrate slowly that drug, because fast titration as well as a high starting dose, it's one of the risk factors for the adverse reaction, which manifests in cutaneous rashes and so on. And as I mentioned, the patients start with aromatic anti-epileptic drugs. All LTG needs to be closely monitored for skin reaction. So what are the takeaways? Know the type of your skin eruptions in your patient. So you in this case, is a neurologist, but you also need to be familiar what kind of reactions to expect. And especially would be, you need to know how to recognize the severe reaction, because as I mentioned, there may be just a highlight to the more severe systemic presentation, like teen or Sjogren syndrome. So she also suggests, remember, to examine the skin, including mucous membrane, palms and soles of feet, and also genital area, because they may happen over there. And this is something patient, I'm seeing neurologists, why should I show my private part and so on. So you actually have to probe, you have to ask questions and so on and so forth. So know your patients, know your risk factors, which I mentioned, feminine, gender, age, and so on and so forth. Also some HLA genotype, it's helpful to identify those patients, as I discussed with you a little bit. Patients with Asian descent or Indian descent could be more prone to those reactions. Be familiar with the history for allergic reactions. And I really like what she wrote. She's Polish, so I'm Polish too. When in doubt, stop the drug. It kind of had a good dream, and the sooner the better. So I do apologize. I will not be able to answer your question unless you have a question pertaining to cardiology, which I'll be happy to answer. But this is my last slide, so thank you very much for your time.
Any more questions? Okay, maybe only one question I have. Is the myocarditis that you, I know you are a cardiologist. Yeah. So is it because of the idiosyncratic reactions of the drug?
I think what it is associated with an allergic reaction and response on a cellular level to the drug. Mm-hmm. So usually the skin is the very first organ which manifests, but sometimes you may have involvement with the renal organ, liver.
That's exactly. So non-specifically it may act.
That is actually, it's a very highly inflammatory process which occurs in the cardiac muscle, which actually affects the entirety of the cardiac muscle. So then the question of the fibrosis occurs, so the heart cannot contract appropriately when they need to be heart failure. So
that's okay. It's sort of an immune reaction. So it's more of an immune reaction than a drug. Mediated by the drug, yes, I do agree. Yeah. So with this, I thank you, and yes, it's more appropriate to put your name on this, but unfortunately I cannot know.
Actually, she would do a magnificent job.
Okay, then please convey this. Please convey this to her.
I accept the photograph and thank you very much for your time. Okay? Thank you.
Thank you so much.